Hello, everyone, and welcome to this month's American Institute of Dental Public Health's Rural Oral Health Echo Session, Innovations in Rural Oral Health Partner and Stakeholder Collaboration. My name is Stacy Chazen. I'm Director of Education and Leadership Programs here at AIDPH, and it's my pleasure to welcome you all here today. Next slide, please. Before we get started, I want to thank the partners for this program, CareQuest Institute for Oral Health, the Oral Health Progress and Equity Network, UNLV, and the National Rural Health Association. We appreciate your continued support. I am going to share the agenda for today, which is on the screen. And before I dive into that, I do want to mention that we changed our standard operating procedure for this month's ECHO. We typically give you a whole introduction to the ECHO model. How that works, we give you an overview of the topics we covered, the topics we're going to cover, and some more background on who we are at AIDPH. In order to carve out more time for presentation and discussion on these calls moving forward, we sent out a recording of those slides with discussion prior to today's call. They'll also be available on our website. So if you'd like to learn more about this program and our organization, we invite you to do so. And we are going to jump right in. So we're going to review housekeeping briefly. We're going to give a call overview to all of you. We're going to have a didactic presentation today from Gina Sharps with the West Virginia Oral Health Coalition and Marshall University, who is going to talk to us about innovations in partner and stakeholder collaboration in rural oral health. We're going to have time for Q&A, and then we're going to move into the think tank discussion part of our call, where we're going to talk about mobile dental clinic collaboration in rural areas. Next slide, please. Quick housekeeping. Today's session is being recorded. We ask you to stay on mute until you're ready to speak. Slides, forms, and the recording and all other materials will be available on our website following today's call. We ask that you please type your email address and your organization in the chat. Also, to add your personal pronouns to your name if you're so comfortable. Please avoid any personal health information on this ECHO session. And if you have any questions about Zoom during the call, please chat with my colleague, Elizabeth Flannery. Next slide. Session norms for the ECHO: each person learns and each person teaches. We ask everyone to use first names. Always introduce yourself when you speak, including your name, your organization, and location, and try to limit any environmental distractions. Please respect one another and respect patient health information. Next slide. The learning objectives of today's call. 1, to describe the West Virginia Oral Health Coalition's policy agenda and the rural oral health challenges that it seeks to address. 2, explore stakeholder engagement strategies for addressing unmet oral health needs in rural areas. And 3, describe promising partnerships that address oral health challenges in West Virginia. And here's our disclosure. Next slide. So today it is my true pleasure to introduce our didactic presenter, Gina Sharps, and I'm going to tell you a little bit about Gina. Gina Sharps has worked in both private and public sectors of the dental profession over the span of 30 years and currently serves as an oral health coordinator with both Marshall University and the West Virginia Oral Health Coalition. On a national level, Gina sits on the National Rural Health Association's Oral Health Initiative Task Force and also acts as the co-lead consultant for the National Center on Health, Behavioral Health, and Safety's Dental Hygienist Liaison Project. Gina is a past president of the West Virginia Dental Hygienist Association and the dental hygiene member on the West Virginia Board of Dentistry. And we are simply thrilled to have Gina here with us today to talk about this topic. Next slide. And Gina, before I turn it over to you, I want to ask folks to pop any questions they have into the chat. You can also feel free, questions or comments or resources, and you can also feel free to hold those until Gina's done presenting and you can ask them verbally. So with that said, I will turn it over to you, Gina.
Very good. Thank you so much, Stacy, and the group for spending a few moments of your time this afternoon. It's a real honor to be here and see familiar faces and friends already on the call. I'm already smiling. Next slide, please. And let me start my timer because I have 20 minutes to get through like 25 slides or so. And Stacy made me pinky swear that I could do it. Just kidding, she didn't. So if you, a little bit of background about our West Virginia Oral Health Coalition. We're a fairly new coalition. We were established in 2010, and our mission statement is to advocate and promote optimal oral health for all West Virginia residents. We're a membership driven organization. We have a 501c3 status, and we're governed by a board of directors. And I always like to say that the work that we do is not what Gina Sharps thinks that we should do. It is grounded in our state oral health plan, and it's also grounded and informed by our West Virginia State Oral Health Report Card that you see there on your screen. So next slide, please. We are also very proud members of ANOC, which is the American Network of Oral Health Coalitions, and I think they say it the absolute best when they talk about the work of state oral health coalitions, and that we play a singular role to advance state and local policies and programs. We also serve as the neutral voice for oral health in the state, and wowza, is that important when you look at tackling scope of issue practices. Right now we're looking at interstate compact. So serving as a neutral voice can be really, really important and critical. And we also see ourselves as bridge builders and change makers as well. And again, very proud member of ANOC. Next slide, please. So back to our state oral health report card, we looked at 15 data points, national indicators, and sadly, out of those 15 in West Virginia, we received Ds and Fs on 8 of those measures. So we have some really glaring oral health disparities that need addressed. You can see the 3 indicators for children that we scored poorly on. Also on adults and workforce. That's a big issue for us as well. And next slide. So looking at our state oral health report card, that helped to inform our policy agenda. As you can see here, we have 5 key issues that we're tackling this 2023 legislative session. If I have a few moments, I didn't put it into the objectives, but I'd love to share a little bit about the emerging work that we are doing around the Oral Health and Cancer Rights Act. If we have time, if we don't, that's okay. We can share later. Next slide, please. So the initiatives that I do want to elaborate on in our few moments together is the coalition's work around the Medicaid adult dental benefit, our work around community water fluoridation. Are really excited to share with you our work around substance use recovery, and that I see Heather from Michigan, who's a dental hygienist liaison, on the call. I'm going to talk, Heather, a little bit about the dental hygienist liaison project as well. And they are all tied to drivers to improve our oral health outcomes in this state, and they require key stakeholder engagement as well. Next slide, please. So looking at our West Virginia Medicaid adult dental benefit, you guys, we advocated for the benefit for a decade. We worked on this thing for a decade. Once we finally got it over the finish line, we kind of thought that's where, I mean, I didn't anticipate to rest on my laurels and do nothing, but we thought that that was like the hard work to get the benefit through the legislature and passed. It did pass in 2020. It has preventive and restorative provisions, but really we had no plan in place after we passed the benefit. I'm saying we, royal we, passed the benefit to promote it. We thought that that's where we would hand the baton off to the MCOs, our managed care organizations, and they would take it from there, but not so. So next slide. I want to talk to you a little bit more about our collaborative partnerships and with our managed care organizations. So I like to call this our first date with our MCOs in West Virginia. We have 3 MCOs. You can see this did not happen all that long ago. This was September of 2021. We invited our MCOs to come present at one of our quarterly coalition meetings and just tell us a little bit about themselves, like who you are, what's your membership base, what does the Medicaid adult dental benefit look like for you, what are some of the challenges that you might be incurring in rolling out the benefit, both with providers and also with membership as well. So it was kind of, I call it the first date, but it was a little meet and greet, and it went really well. Next slide, please. So in West Virginia, we have 3 MCOs, managed care organizations. We work with Unicare, the health plan, and Aetna, and our dental benefit administrator is Skygen. And with the 3 of those organizations, they cover almost 300,000 adults in our state. Next slide. So as a result of that meeting, our meet and greet, our first date, we came up with some joint strategies that we could work together to advance the Medicaid adult dental benefit. And one of the first things that we landed on, and this is not unique, those of you who've heard me chat about this before, it's not unique to West Virginia. We took this is a page from Virginia Health Catalyst playbook. You've heard the saying, imitation is the highest form of flattery. So looking at our neighbor friends in Virginia, they had done a series of webinars, and we did the same thing. And it proved very beneficial. I'll just put it that way. So we did one consumer facing, the other was provider facing. And the other thing that we're doing is looking to monitor and report utilization data of the Medicaid adult dental benefit. And those are just short-term strategies. So next slide, please. All right, here's the first webinar that we did. We call this a lunch and learn, the Medicaid adult dental benefit, use it or lose it. And this again was the membership facing with our community-based organizations. You guys, 185 CBOs dialed in for this first webinar. I was over the moon excited. I was like, wow, this is really, really good engagement for just getting kind of like a first wave of information out. And the community-based organizations are the organizations that are on the ground that are actually working with individuals that have the Medicaid adult dental benefit. Lots and lots of questions ranging from, do I have to present a dental benefit card to the dentist? How can I find out who the providers are? So a lot of really good questions. And as a result of that, we came up with an FAQ that we shared back to the CBOs. Next slide, please. The next was with our dental providers, a little less. So we had around 100, which is really good. I feel that was really good engagement as well. And we titled this one, which I love the title of this as well, the West Virginia Medicaid Adult Dental Benefit, Time for a Checkup. And this one also led to the result or publication, I should say, of an FAQ document. And we shared that out with our state dental association. The questions, as you can imagine, the flavor of the questions was really different with dental providers. It was a lot more around pre-authorization, timing of payment, those types of questions. But it was really good to get the conversation started. Next slide. Now, monitoring the data, super, super important. So we're working with the MCOs to help track utilization rates. And as you can see here on the slide, it requires partnership with our MCOs and also our key legislators. And what great timing in ADAs, we talked with the managed care organizations, have been working with them to track the data. November 1, 2022, you can see the publication from the ADA Morning Huddle Office Edition with the headline, West Virginia Medicaid dental benefits don't go far for patients. So like, what fantastic ammunition that gave us to go back and say, okay, let's look at this a little bit more. We know that folks are utilizing the benefit. What can we do better? Do we need to bump up the ceiling on this from 1,000 to 1,500 to 2,000? Just really good conversation starters. And then also, what are the concerns? And if there are concerns, what's the coalition's role in this with our key stakeholders? What can we do to help address or mitigate any of these issues? So next slide. And we can also parcel this data out down to county level, which is really important in West Virginia when we look at dental deserts as well. Next slide. This is also not unique to West Virginia. I don't see Sarah Holland on the call today, but I can definitely want to recognize her efforts in Virginia Health Catalyst. Again, this was taken, we took a page from their playbook. This is a promotional card that offices, dental offices can mail out. We have this on our coalition website, and we just encourage anyone, if it's a private dental office, one of our community-based organizations, take this, rebrand it for yourself, get the information out there that yes, there is a Medicaid adult dental benefit, and please utilize it. Because in times when it gets lean and mean, what's one of the first things to go on the chopping block? The Medicaid adult dental benefit. We do not want that to happen in West Virginia, especially after we fought so long and hard for it. Okay, next. We also developed a white paper, and this is Helen Hockey's not on the call, I don't think, but I'd have to give a hat tip to Helen Hockey and her group for developing this and allowing us to co-brand it. But this is it's a white paper, but it serves the importance of engaging other organizations around the state, whether it's our MCOs, our dental schools, our federally qualified health centers, to endorse this effort. And this is really important when you take this to and you're talking to a legislator, to say, look at all these organizations and key stakeholders that believe in the benefit. Thank you for your support. And can we count on you for continued support? Next slide, please. So we're going to switch gears. That's all I have to say about the Medicaid adult dental benefit. I want to talk a little bit about our work around community water fluoridation. You all know, when you look at public health interventions, evidence-based, CDC stands behind two. One is dental sealants, the other is community water fluoridation. Next slide, please. We perform so poorly on many oral health, or not just oral health, but health indicators in general in West Virginia. This is one that makes me smile. We actually are doing really well with this. We're coming in at number 13 in the nation at 91% of population served by community water systems receiving fluoridated water. But we're doing well on it, but we can do better, right? We can always do better. Next slide, please. So okay, let me just say a little bit about this one here. Sorry, I had in my mind this was a different slide. My mistake, but no problem. So we also developed a white paper around community water flow. I'm saying we. This is not we. This came out from ASTDD. This is their template. They allow states to personalize, but this, I could talk for 30 minutes about the importance of this white paper and how we were able to show endorsements to certain organizations when they are in times of challenges and rollback attempts, to say, these are the organizations that support community water fluoridation. And if you're a member, your organization is on board with this. This has proved very beneficial to us. Next slide, please. Oh, okay. This is what I had in my head was next. This is talking about our work with NACHO, which is the National Association of County and City Health Officials. And plus it's just fun to say NACHO. Next slide, please. So a few years ago, our coalition applied and received dollars from NACHO that allowed us to this was a brand new partnership with us, you all. This was with our West Virginia Department of Health and Human Resources, not a new partner, but the Division of Environmental Engineering, new partner. This allowed us, and this might not seem like big numbers for you, but this was a big deal here in West Virginia. I mean, we only have 1.5 million people, 1.8 million people that live in this state. So we had 4 water systems that were able to upgrade their equipment, and 1 water system that was able to initiate community water fluoridation. And I just put in here the town of Gilbert, West Virginia, very rural population, 8,000 and change. That picture, those of you who work in the space of community water fluoridation, you all know what that is, right? That's a day tank for a community that holds fluoride. That little baby, that's chump change, right? Budget dust. That's not a lot of money at all. That you all provided that layer of protection of community water fluoridation to that community. Like, really, really proud of that work and proud of that partnership with our engineers. And we were able to use that as a springboard to say, hey, you all, talking to our private philanthropic organizations in the state, look what we did with just this small amount of money. Would you be willing to fund the coalition to do this again? And they said, one of the foundations said yes. So we did. So it's just, it keeps going, and we're really thrilled about that. Next strategy. Next slide, please. Okay, of course, those of you all are like, have your grammar spell check on, you're going to go right to the headline. This article will forever haunt me because fluoridation is spelled incorrectly. I did not do that. It's okay. But we utilize that opportunity to get this information out in the quarterly publication of the Mountain State Water Line. And this targets all the environmental engineers for them to see their role. They you know, when they're doing their training around community water fluoridation, it's just the mechanics of community water fluoridation. They don't really get a lot of the, unless they're schooled by Dr. Johnson and co with American Fluoridation Society, then they get the public health slant, but for the most part, they don't. But this was an opportunity for us to say, hey, you have such a critical role in advancing the work of community water fluoridation, because who gets, you all know, who gets the phone call from the anti-fluoridationist? It's not Gina Sharps in her role as the coalition coordinator. It's my local water department and my water operators. So for them to kind of package this and to say you have such a good or a critical part in this, I just think it was genius. Next slide. How am I doing on time? 3 minutes. Okay. I promised Stacy I could do it. So we were building off of community water fluoridation in the time of COVID. You guys, if you would walk into an elementary school, what did the water fountains look like during the time of COVID? How about, I'll tell you what they look like. They were covered up with black trash bags with yellow caution tape around them. So how much community water fluoridation or fluoridated water were children and staff receiving during that time? Like goose egg. So we went back to one of our philanthropic organizations and said, hey, what do you think about putting in water bottle refill stations? They said yes. 81 refill stations in 63 schools with a reach of $24,000. Very modest investment. Next slide. Talking a little bit about our work with substance abuse. And sadly, you all know, you've heard the terms, West Virginia is the only state that's entirely in Appalachia. We've referred to as hillbillies. You've heard all the Appalachian slang. And then, of course, with substance use recovery, have you heard the term pillbilly? Isn't that just like the most sad? Zill, I see Zill shaking his head. He might have heard of that term before. It's just so sad. But West Virginia has been just plagued with the opioid epidemic. And it's just not good. So there is a role for the coalition to help address this. Our partnership here is with the Greater Kanawha Valley Foundation. And you can see on the second bullet there, sometimes there's a need for education. You'd all agree with that. Sometimes there's a need for direct services. With individuals that are substance use recovery, they need money for direct services. They don't need to call and talk to me on the phone about the importance of brushing their teeth. They need their teeth fixed. What we don't want them to have is a toothache, and then they need pain medication and end up back in this vicious cycle. So with our work with substance use recovery, we cover up to $2,000 per patient. We do ask that providers bill Medicaid first. We're working really, really hard to build our provider network. Right now, we have 20 providers in our network. I'm going to pause right there and say we're doing something very, very similar with our West Virginia chapter of the National Hemophilia Foundation. Individuals with bleeding disorders are on the struggle bus as well, trying to secure dental services. So we have a couple of different initiatives that we're working on. I'm under the 1 minute mark. Stacey, I'm getting ready to land this plane.
We're good, Gina. We're good.
Next slide, please, and thank you. So it's always important with funders answering the so what question. Don't you agree? Like, so what? So we know that the evidence shares that individuals who receive comprehensive dental care have a better quality of life, as measured by substantial improvements in employability and drug abstinence, as well as a dramatic decrease in homelessness. I think you all would agree those are critical issues. Next slide. I'm not going to cover these. I do hope you take time to read these if you have an opportunity to review the slide deck. This is just a perspective from one of the dental providers that is in our network who agrees that you can see what they say. Oh, that's my timer going off. That they've lost that patients that come in like they're shy, or they've lost their sparkle. they've lost their confidence, and by restoring form and function, it provides, just a new lease on life. How beautiful is that? Okay, next slide. It's going to be some of the same things. It's been so long since I've had any teeth, I forgot how great they feel. Wow. Like, if that doesn't make me want to get up in the morning and get right to the computer and start working and helping these individuals. Next slide. One thing that I want to pull out here is this individual, and we have permission to share their names with you all. This individual actually works for the health plan, one of our MCOs in the state. And she says, I am sure you are aware, when those of us who have gone through active addiction, dental health is the last thing on our minds during that time. My teeth have been the last visible sign of the tolls that addiction has taken on my body. I wasn't sure if I'd ever be comfortable smiling again. So how powerful is that? Next slide. I'm not going to read that one. You can hopefully read that one a little bit later. It's so good. The next one is so good as well. Okay, next one. I think this is going to bring me to, yes, it is. Now I can call in Heather to drop something in the chat if she wants to. So last but not least is the partnership with key stakeholders with the Federal Office of Head Start, the Association of State and Territorial Dental Directors, and the American Dental Hygienist Association. In every state, there's a hygienist, such as Heather in Michigan, that serves as a dental hygienist liaison. It's a volunteer role, and what we do is act as conduits, taking evidence-based information and sharing that out with local Head Start centers. So thinking back to our state oral health report card, those poor indicators around children's poor oral health, this is one of those initiatives that gets right to that. Okay, I'm not going to do the next two. Go ahead, Stacy. Or I think that's Sarah that's driving.
You're okay. You're okay. We have a little wiggle room.
Okay. All right. Fantastic. And I'll just say a word about this one. We have a free social media toolkit that I would encourage you all to check out, because it is fantastic at promoting five key evidence-based information messages, around the importance of brushing with fluoridated toothpaste, not sharing or not putting, we call it storage wars, not putting toothbrushes in the same container so they're touching, so no cross-contamination. And these messages are going out to parents and Head Start staff as well. Okay, next slide. Oh, I do want to say just one quick word. I'm so excited about this work, very proud of this work, because it's going to pass. I know it's going to pass in this year's legislative session. It was so close, teetering last year. Individuals, and I get really jacked about this one because I am a cancer survivor. So individuals that are going through cancer, oral facial cancer treatment, their insurance carrier will cover that. But if there's any sequela, damage, fallout from that, guess what? Insurance companies don't cover that. What the heck? So we are going to get this through the legislative session this year, and we're going to work with those insurance companies. I know, right, Heather? Whoop, whoop. And they're going to cover that. So individuals, that it's kind of the same with substance use recovery, restoring form and function, getting their self-esteem back. This affects their employability. Like, I'm really, really stoked on this one. Next slide. I think that's it. It is it. Okay, I might have been 2 minutes over. So close. Thank you all.
Great,
Thank you.
Gina. Thank you. And we're giving you a little wiggle room in part because we're actually going to stay in one big room together for our discussion later. So we save a little time with moving in and out of the breakout rooms. Thank you. That was wonderful. And your excitement and passion for this work are truly infectious. Are there questions for Gina? Feel free to pop it in the chat or to raise your virtual hand. Heather.
Not a question, just a comment, Gina. When you shared that postcard, I'm going to forward that to our oral health coalition, because here in Michigan, we increased adult dental Medicaid benefits, increased reimbursement tremendously, and we increased services. So I just want you to know that I'm going to share that and possibly reuse that here. So thank you. Very, very great presentation.
Oh, Heather, thank you so much. It's always a joy to see you and use away.
Sounds good.
Yes, you bet.
Gina, I have a question for you.
Yes.
I'm curious. Well, actually, I'm going to go to the question in the chat first. What does that yellow tank do?
It's a bulk tank day holder. So for it holds the actual fluoride element component.
Great. Thank you.
That's where the magic happens. With the 25% reduction of tooth decay. That's where it comes from.
Amazing. I was curious if across these community and partnership engagement experiences,
yes,
are there any, one or two key lessons, key takeaways that you would share with folks who are thinking about doing something similar in their states? Anything that worked particularly well, or anything about the experience that you think would be most instructive to folks?
Yeah. So my first thought, and sometimes I get this statement, like not absolutely what is that, vice versa or whatever. People don't know how much people don't know how much you care. Does anybody know that statement? Like, you have to demonstrate to individuals that you really care. So whether it's for me, I'm 2.5 hours away from our state capital. So it's kind of a pain in the rear to get in a car and drive to Charleston and sit down and meet with environmental engineering when you could get on the phone call. But that, Stacy, is so critical. So making sure that you're authentic and you're transparent and you put in the time in those relationships, and you can't be sporadic. It has to be consistent with these key stakeholders, and just the authenticity of forming those relationships. Like, that's one big thing. Like, all of those organizations, and you can see, like, I could go back some of that information I'd started at before. I was like, geez, that's a little bit dated. Like, that's 5 or 7 years old. Yeah, it is 5 or 7 years old, because I'm building on a relationship that I started 5, 7, 10 years ago. And it takes time.
Thank you. And Caroline put in the chat, people don't know how much you care until you show them.
Yeah.
Yeah.
I don't know. I struggle with that. Well, I'm sorry about that. I hope you all will give me a measure of grace and forgive my fumbles.
It's all good. It's all good. Thank you so much, Gina.
Yeah, you bet.
All right. So we're going to now move into the think tank portion of today's call. And we're going to share a case with you and do some collective brainstorming and problem solving in our room here together. So here is the case. A farming community in Iowa faces challenges accessing oral health care due to distance and financial constraints. The local health department partners with a mobile dental clinic organization to provide comprehensive oral health care services on a recurring basis. Our questions for you to consider on the next slide are: how can the local health department collaborate with the mobile dental clinic organization to identify suitable locations and plan for the schedule for mobile clinic visits? 2, what strategies can be employed to engage and involve community leaders, schools, and local businesses in supporting and promoting the mobile dental clinic's visits? And 3rd, discuss the importance of ongoing communication and coordination among the health department, the mobile clinic organization, and the community to ensure the sustained success of the initiative. So I'm going to give you a few seconds to chew on that. Great. And thank you to Liz has posted the case, the description, and the questions in the chat. So you can see it there.
I was thinking, Stacey, we might want to stop our screen share so we can all see what we discuss, if you're okay with that, Sarah. We have it in the chat.
Great. Now we can see many of you. And if you're in a place where you're able to turn your camera on, we'd greatly appreciate it. Thank you, Beth Stewart. Oh no, she left. And Christina, thank you. And thank you, Mike, and to Zill and to Heather, who've had their cameras on the whole time. There you go. I guilted Beth to come back. Welcome back, Beth. Okay. So we're recording. We're also taking some notes. So this is something that we can pull together in a summary that we'll share back with all of you. Why don't we start with the first question? So how can the local health department collaborate with the mobile dental clinic organization to identify suitable locations, recruit patients, plan the schedule for the mobile clinic visits? So that logistics piece of it, how can that be done in collaboration?
Stacey, this is Christina. Can I chime in?
Yes, please.
Sorry, and my voice comes and goes, so I apologize if I start coughing. I think what's important would be within the health department or the mobile dental organization, has there been a needs assessment? Do they know, like, is there any preliminary data? Iowa is very vast. Iowa probably has a lot of state data. So do they have access to the data? And specific to that, that can help them hone in on a population. Here in Las Vegas, we are actually working with our health district to expand upon dental services. So actually looking to see within the health department, do they even have any dental health or public health or medical services that would align with the goals of the mobile? And just specifically looking at the workforce. I mean, how many providers do they have? What's the scope of practice? Can a dental hygienist offer some services? Does it have to be a dentist? So I'd say looking at the needs assessment of where it is and then where the resources are. Do they have availability or access to resources? Maybe working with a dental school, working with a coalition to enhance or beef up some of those workforce models.
Wonderful. Thank you.
And I think to go along with that environmental scan and just thinking about the presentation we just saw, I think it could actually be really, really important for the two parties to take time to meet together. Face to face if possible. I think, Gina, you made a really good point about that, especially when you're starting a collaboration. And I was thinking too, you even said oral health collaboratives are a neutral convener. So I think an oral health collaborative could potentially assist in this type of thing to help them meet to discuss, you know, what capacity and skills and resources they bring to the table. What do they still need? What outcomes or intended impact are they hoping to make? That way they can align on those types of things before they really even get started, like planning all the logistics. So you're not down the road with all these plans and then you realize you actually had two different goals in mind based off of, you know, whether you're the health department or the mobile dental clinic. So I think that could be a really, really important first step.
And Caroline and Christina, too, to me, and I don't know if I'm violating a facilitator rule here, but to me, that suggests the importance too of when you're talking about that face-to-face and connecting, that relationship building that's needed, right? That can be helpful between the two organizations as they get started and move through the process. Other thoughts on that, including identifying the patients who are due, figuring out any other logistics. Any other thoughts on that?
You know, I'll share, Stacey. One thing that comes to mind for me is the use of non-traditional partnerships. And that kind of goes into question to strategies that can be employed to engage and involve community leaders. Because I think it's about identifying maybe the congregant areas or communities that don't naturally come up, like local businesses or faith communities, places where there are a lot of people who, a lot of people do attend, even in rural areas, they'll attend their church or, go to events around their faith tradition. And so figuring out where people go and then partnering with those people feels like a way to answer number 1 and 2 in my mind.
Yeah, great point.
I agree, and I'll piggyback on what Annalise was saying. In some of these farming communities, they are so small, there is no community health center. You're lucky if there's a rural health clinic, but also sometimes these services may have to be performed at a church. They may only have one church in that whole community or one school for all grade levels. And so that would probably be the place where they would center, but you've got to involve all of those community members, those community leaders as well in some of this. And then they will in turn help you look for the patients, see which patients need to be seen first, especially in the schools, with children and things like that.
And I'll piggyback off of what Beth said here, but being able to engage the local level, like you said, there might be just one area where you can focus on, one school, one church, one whatever general location, but taking the initiative to say, all right, well, we've met with the, whether it be the local health department partners or the mobile dental clinic, one or the other, saying, let's meet with whoever's running that system, whether it's the church or the school, and saying, all right, you can help us triage what the priority is. And so once you've gotten further along in the process, picking out your key identified people who can be helpful to you, and they'll help you understand where to triage.
Great. I see Sarah added in the chat, community leaders can help identify those third spaces or gathering spaces that are not work or home. Yeah, thank you for that, Sarah.
I think community leaders know when to be there and when not to be there, because I think that's a thing that happens constantly with mobile care, that they come and they set up a time when it's really inconvenient for whoever they're trying to get to. Then the second is for sure one issue with mobile care is continuity. So first about continuity, how often they'll come back and when they'll come back, but also a plan for urgent needs while they're not there.
Mike and Sarah, you bring up a concept that AIDPH has really authentically tried to implement, which is a community engaged research model, where our first step is to actually go to the community that we are wanting to partner and collaborate with, and that they are leaders start to finish all the way into the implementation phases. And when I think about a mobile clinic, implementation and research is you're applying the results in their community, but thinking through how a local health department could effectively and authentically engage for true oral health, not just a one-time clinic or a quarterly clinic, is ensuring that those community leaders have a say in the way that things are developed, and that those community leaders are equipped to help people potentially find services after, or thinking about sourcing toothbrushes, or having people really be focused on oral health in other areas where it's oral health in all policies and places kind of thing. So I think that really engaging start to finish and allowing the community to help lead the development, and having folks serve as the technical expertise or the resource gatherers can be a more effective way of authentically involving the community.
And we've moved into, so these questions really do feed into one another. I think we've moved into already discussing the importance of ongoing communication and coordination among the various partners. Any other thoughts on that or examples of that? And I'd also be curious, as you're thinking about that and reflecting on the other two questions, if folks have any firsthand experiences in this space that they'd like to share.
This is Christina, Stacy. I think part of that, I think everybody's hit upon it, is that continuity of care, like Annalise was saying. when we're using portable equipment or working in a church facility or faith-based organization facility, there might be certain limitations. So we really have to know what the resources are. If, let's just say, it's a more extensive procedure or the patient is medically compromised or complex cases. So I think also not just continuity of care, but really understanding what other resources are available if that mobile clinic has to move on or if that health department is no longer available. So having, I guess, a sustainability plan, but more specifically, where can the community members go if those two entities are no longer available?
Right.
I'd like to ask a question of the group because the words that I latched onto from question number 3 were sustained success, ensure the sustained success of the initiative. I'd love to hear more, as Stacy kind of alluded to in her question, what tactics have people used or implemented to ensure that sustained success of initiatives like this? I'd love to hear more if anyone has that knowledge or expertise or even ideas.
I think something that's really important when you think about it's like sustained success is how do you even define that or how do you measure that? So I think that's a really important conversation to have, upfront during question 1 as you're getting started, about how you can measure success and tracking that over time with whatever measures that looks like: improved utilization, access to care, improved health outcomes in this particular population, whatever that would look like for your project. And then as you're going along, hitting certain milestones every, month, quarter, year, whatever it looks like for the project, looking at those metrics, and doing that in tandem, I think, with the community. Annalise, I think that is a really important point that you called out, is almost a beginning step to understanding if your success is sustained, if that makes sense.
Heather.
One thing that I've done in my role as in Michigan as the early childhood oral health specialist is that I let me lower my hand, is that I joined the farming community question kind of got me thinking. I joined the Michigan Migrant Task Force. So I'm a resource now for the local Department of Health and Human Services folks and the migrant folks. We have 4 outreach events. I don't provide any like clinical treatment, but what I am is I'm a resource, and they know the local folks that they can contact me. So that's just thinking outside the box a little bit. I think it's very valuable for me to go on these outreach events. They pass out diapers and wipes and clothes and that kind of stuff, but they know who I am, and they know that I'm here as a resource. There's just something different.
Anyone else? Anyone we haven't heard from yet today?
I'll chime in quickly, Annalise. When you're talking about sustained success, I think, we talked a lot about the community leaders and having that be a start point to get us into these communities and start these partnerships and initiatives. And as the programs move on, I think it's important to go from a broader level almost to a more granular level and be looking at the folks that you are serving, who those leaders helped you reach, and whether it be through anecdotal talking with them, gathering information, to formal surveying to get the information from those folks if they're happy with the services or if there can be different times, different ways the service is being delivered, etc. So almost go from broader to more granular on who you're working with.
Thanks for that, Liz. Any parting thoughts before we move into wrap up?
Stacey, I have, I think Annalise was asking for an example. So at the dental school, we do a lot of different activities through UNLV, but we identified a school in a local community that had a lot of need. And the need was medical, dental, mental health, financial, etc. So what UNLV in general did, from the president, the provost, all the way down to all the units, was we each volunteered our time. So we just had an event 2 weeks ago. Each of us is contributing time and resources available. But it started because an internship student did a needs assessment. So they went in and asked the parents, what is it that we can do from you? So I think a lot of times we think we know what the community needs, but if we don't ask that specific question, what do you need and how do you want it delivered in a very culturally appropriate manner? Because there's a lot of families or refugees at this facility, so at this school. So I think it's just really addressing what the need is of that respective community. And for us, all of the units across the board actually did it. So for sustained success or sustainability, it's like the continuity, having the same people as the resources from year to year to year to be consistent and systematic in the care that they offer. And to have the president handed out backpacks is nice in 110-degree weather. So to have the president of the university doing that, that was nice. And the dean of the dental school came and helped us open up and pass out toothbrushes. So I've never seen that in my 20-some years here at the school. So to have the top-down individuals helping, I think is very good. So that engagement from all levels of our career.
Fabulous. Well, thanks, everyone. We look forward to providing you with a summary of today's really rich discussion. Sarah, could you take us back to the slides, please? And we'll go on to the next one. Okay, so CEUs are available for today's session. Liz has posted the CEU request link in the chat. You can grab it there. It'll also show up in your browser after this call and will be available on the AIDPH website. We'll also be posting the recording and resources from today's call, a strategic recommendation summary. All of that will be available in the coming weeks. We invite you, by visiting our website as well, to apply to share your own organizational, community, or clinical challenge on a future ECHO call related to rural oral health. And our next call will be on October 19th at 2 p.m. Central Time. We'll be focusing on patient engagement and communication. I want to say thank you again to our wonderful speaker, Gina Sharps. It was a true pleasure to hear from you, to learn with you. And I thank everyone for being so engaged in the discussion, both following Gina's presentation and during our think tank. And I think that is all we have for you today. I think our next slide is a farewell wrap-up slide. And I will wish you all to enjoy an extra 7 minutes back in your day.
Hey, Stacey,
thank you, everybody.
Stacey,
Yes.
can I say one final word? I
Yes,
did not
please.
see, I'm so sorry. I did not see Beth Stewart on the call. Is she still on here? Oh, there she is. I didn't see you. Beth is one of our regional dental hygienist liaisons, and she is a total rock star. Beth, I didn't see you. You must have been on the second screen, but I did want to take a moment to acknowledge Beth's work around the dental hygienist liaison project as well. And I also found the quote that I was stumbling all over, and it's from Theodore Roosevelt. People don't care how much you know until they know how much you care.
Oh, that's good.
It's very good. And I'm not going to say that again until I have it memorized, but thank you.
It was
Don't
good
care how
presentation,
much you
Gina.
know.
Thank you.
People don't care how much you know until they know how much you care.
Bang. That's it.
Caroline's version
Bingo.
was good too. That was even better. So thank
totally.
you. Caroline,
Yeah.
thanks for getting us halfway there. And thank you,
Yes.
Gina, for everything. You're a wonderful group, and we will see you back here in October. Take care, everybody. Bye-bye.
Thank you, friends.